Good evening, everyone, and welcome to our virtual family council meeting. My name is Jamie Rose. I'm your virtual meeting coordinator. So we're going to kick this meeting off with our confidentiality statement. Just a reminder, please refrain from using the name of your loved one. Do not name specific facilities. Please use a nursing home or the personal care home to present to the group. If you need specific assistance, please use the chat feature to state which county you're in, and we will get you connected to your assigned ombudsman. And a reminder, these calls have public access and are designed for family members and friends of residents in long-term care facilities. Review our meeting agenda. We're going to get our virtual meeting tips from Jay, and then we're going to turn it over to Sydney and hear about Hospice 101. And then at the end, we're going to review our upcoming meeting topics through May. So we're pretty excited about that. So without further ado, I'll turn it over to Mr. Rotz for our virtual meeting tips.
Thank you, Jamie. First of all, folks, you've been placed on mute upon entry. We'll open the lines in a little bit so that you're able to share with us. If you would like to speak or have a question, please use the raise hand feature. Once you raise your hand, we'll know to acknowledge you and we will unmute your line. If you hover near your mouse near the bottom of your screen, you will see the Participants tab. This can be expanded if you'd like to see that. The chat feature is at the bottom of the screen as well. Once you maximize it, you will be able to send questions to the chat moderator or others during the call. Closed captioning is available during today's call. To enable this feature, push on the CC icon at the bottom of your screen and choose to enable closed captioning. If you need to step away, you can stop sharing your camera by clicking on the camera icon at the bottom of the screen. You can click on it again to start sharing your camera again. And finally, concerns or complaints can be directed to me at the State Ombudsman Office. That's 717-783-8975, or by email at ltc-ombudsman@pa.gov. And now it's my honor today to introduce Sydney Hill, the marketing manager for Kindred Hospice, and she is here to speak to us about Hospice 101. Sydney, take it away.
Thank you so much, Jay. Can everybody hear me okay? All right, wonderful. Well, thank you so much for having me. My name is Sydney. I'm with Kindred Hospice. I am the marketing manager. I have been here for it'll be 6 years in September. Can't even believe it. I started as the volunteer coordinator, functioned as a care consultant, and now I'm the marketing manager. So my primary responsibility is to work with families, work with the community, and kind of bridge that gap between you all and our providers in the community, which consists of hospitals and physicians, personal care homes, and skilled nursing facilities. So I really appreciate you having me today, and we're going to dive right in. So I created a little interactive section. I really like to do the myths and facts about hospice. So I like to dispel some common myths. There are a lot of misconceptions about hospice out there. So we're going to start with an interactive portion. Anybody who wants to, please open up your chat dialogue. And I'm going to give you a phrase, and they're all up here on the screen. And you let me know if you think it is a myth or a fact. After we get a couple answers, I'll give you guys the correct answer. So we'll start with our first statement. Hospice is for those who are close to death or actively dying. Do you think that is a myth or a fact? Thank you, Brenda. Thank you, Corey. Thank you, Stacy. I'm getting a lot of responses. Great. You are all correct. That is most certainly a myth. So that is a common misconception thank you, Linda, both Lindas. That is a common misconception in the community. So the earlier the need for hospice, is identified, the more benefit that the patient and the family actually receive from the care. So it leads to a higher quality of life, a higher level of trust with the people that are coming in to help care for your loved one. And honestly, you think about people that you've known for a couple of days as opposed to weeks or months, and sometimes even years, that you build that trust with. So it is a benefit that is greater for people who are needing that benefit earlier than close to death or actively dying. So my next statement is, hospice is a place. Do you think that is a myth or a fact? Great. Awesome. I'm getting a lot of responses. You are correct. That is a myth. So hospice occurs wherever our patients call home. That is in a variety of places. That can be their private home, that can be a personal care home or skilled nursing facility. And actually 80% of the care that is provided is to patients in their direct primary home. So then my next statement is, hospice is about giving up hope. Myth or fact? Wonderful. Thank you, everybody. It is a myth. So you are all correct. Hospice is about quality of life. We encourage our patients to live life to the absolute fullest. I'll tell you a really quick story. We had a patient who wanted to go, hadn't been to an Altoona Curve game in a long time. So we were able to get him there with his family, and I'll tell you what, he ate a hot sausage sandwich, a funnel cake. We had a wonderful afternoon, and he actually placed a photo of all of us together on that day by his bedside and told a lot of his friends and his extended family members about how much fun that we had. So when we're thinking about hospice patients, we're thinking about quality of life and living life to the fullest and doing things that you want to do. All right, hospice care is only for cancer patients. Myth or fact? Great, thank you, Stacy. Thank you, Jamie, Brenda, Mrs. Hetzel, Eileen, Linda. Thank you guys so much. You are most certainly correct. So it is not just for cancer patients. Hospice can come in for a variety of different diagnoses. We look at Alzheimer's, we have COPD patients, renal disease, liver disease, to name a few, and we'll get into that in some later slides, but it is a myth. My next statement is, the Medicare hospice benefit covers more than 6 months of care. It covers more than 6 months of care. Do you think that's a myth or a fact? All right, great. Awesome, everybody got the correct answer, so it is a fact. So a lot of people think after somebody is on hospice care for 6 months, they have to start paying out of pocket or they're kicked off of the program, and that's not accurate. Medicare hospice benefit covers care for the duration that the patient is on care, however long that may be, as long as they continue to meet the criteria outlined by Medicare that is evaluated by the nurse. So the next one is, if you choose hospice, you can never see your family physician again. Is that a myth or a fact? Great job. All right, great job. It is a myth. So that is a myth. We like to incorporate the family physician into the care. So when we're looking at it, our patient and our family are at the center of our care. And then we have our team and everybody else who was providing care to the patient prior to us becoming involved. And the family physician is a huge piece in that we start to incorporate, and they're regularly informed on our services and have to sign our orders and things like that. So they are incorporated. All right, my last one. I haven't tricked anybody to this point, so we'll see if we can go 7 for 7. Hospice care is expensive. Is that a myth or a fact? All right, great. It is a myth. Great job. So hospice is a covered Medicare benefit, and most private insurances and Medicaid will also cover the services. And in addition to the services being provided, hospice will cover medical equipment and prescriptions relating to the illness. And we'll go through that as well. But great job. We did 7 for 7, so that is fantastic. Everybody deserves a ribbon. So we'll move on now to our next slide. Before we go on to that, does anybody have any questions? If so, please pop them in the chat or raise your hand and we can address those immediately, but I'll keep going unless anything pops up here. So who needs hospice services? So when you're looking on Google or you pop open a dictionary, the first thing that's going to come up is we're looking at somebody who has a terminal illness with a prognosis of 6 months or less. Now, with that being said, people are not defined by dictionary definitions. So there are things that we look at and that physicians look at to make an appropriate hospice recommendation or referral. And the prognosis has a lot to do with that, but we are humans and we are not following a dictionary timeline. So I say that loosely, but if you look that up, that is what is going to come up. We're also looking at patients who no longer want aggressive treatment or that aggressive treatments are no longer an option. And for everybody, those treatments and appointments and testing and things like that look different for everybody, but we're looking at comfort over curative and trying to remain in your familiar environment, whether that's you call home as a private residence or in a nursing facility. We are quality of life focused. So oftentimes I hear our nurses say, if you want to eat that whole bowl of ice cream, you know, your doctor may have discouraged it before, eat that full bowl of ice cream. And of course, it's a case-by-case basis, but we really look at quality versus going a more curative route. So my next slide is, it lists all of the common hospice diagnoses. So we did touch on this with our myths and facts. So this lists all of the different diagnoses that hospice can come in for. And I thought that this was a really important slide so that everybody could see, you know, when the doctor is looking, they are looking for a diagnosis, you know, related to declines. And this is kind of where they start. All right, my next slide, who pays for hospice services? So Medicare is typically, a lot of people that are receiving the services have Medicare, and that is typically the primary source of coverage of hospice services. Now, with that being said, Medicaid can also pay for the services as well as private insurances. Now, all hospices across the board will accept Medicare and most accept Medicaid. Where it gets a little bit tricky is if they don't have Medicare or Medicaid and you're looking at private insurance, some providers will contract with different insurances. So making sure that you know when you're asking questions, if you're interviewing a hospice, that you let them know what your loved one's insurance is. It's really important, and asking if they do accept that insurance. And then self-pay also is an appropriate form of payment as well. For each hospice, it's different, but it's a rate of cost per day, and they would go through that as well. And there typically aren't that many, but there is an option for that as well. Okay, so under that coverage, whether it's Medicare, Medicaid, private insurance, or self-pay, medical equipment and supplies are covered under the hospice benefit. So I listed some different examples of things that we provide. It's not limited to this list, but a hospital bed, oxygen, wheelchair, bedside commode, there's shower chairs. I have wheelchair listed twice, so it's a very important item. Diapers or Depends, the underpads, gloves, wipes, wound care items, and any essential product needed to provide proper care. There are certain non-covered items, specialty pieces of equipment we get asked about. Lift chairs often. Lift chairs are not covered in the hospice benefit. And the nurse kind of outlines, and you're able to get a list of non-covered items, but these are all of the items that are covered. And the way that they are done by most hospices is they contract with an equipment company, and those pieces of equipment are delivered directly to the home. And then they're also picked up when they're no longer needed. So medications are also covered under the hospice benefit. Now, when we say medications, we're talking about medications related to the terminal diagnosis. So this is going to change depending on what diagnosis your loved one would be on hospice for, and anything related to the relief of symptoms. So those are things that, you know, if you ever had those services in place, just being really open and asking your nurse should know what those medications are that are covered. And if they are prescribing anything for relief of symptoms, all of those medications would be covered as well. We always say you should see less or the same pharmacy bill if you see a pharmacy bill, never more when hospice gets involved. So we're going to go through, so we talked about the equipment, we talked about medications. Now, what are you getting in regards to care for your loved one with hospice services? Oh, I see a couple questions. So I have two questions. We're going to take a quick pause. What if the patient changes their mind and wants aggressive treatment after they signed up for hospice? So that is a great question. So at any point in time, a patient can revocate or dismiss hospice services for any reason. You don't even necessarily have to give a reason that you're pulling off of services. The hospice typically would have a paper signed that you are waiving your election of hospice and that you're declining that treatment at this time, and then you can go seek aggressive treatment. And that does happen. People do change their minds, so that's a great question. What I will say is, per the Medicare hospice benefit, every time somebody comes off of hospice services and then tries to come back on, they start to look at the chart a little bit more strictly, just to make sure that there has been decline and then that person does meet criteria. You know, after 2 or 3 times, they start to look at it a little bit more strictly, but, you know, anybody can come off of services as many times as they want. And then I have another question. Aren't most regular medications discontinued with hospice diagnosis? So that's a great question. It's a case-by-case basis. It depends on what the medication is and what it's used for. So typically on the first visit, the nurse would go over those medications with you and talk about ones that may no longer be functioning the way that they were, or may no longer be needed. But they typically don't just come in and say, we're completely cutting all of these medications unless it's completely unsafe to be taking the medications. So that's a great question. And I hope I answered those effectively. They're hard. It's a case-by-case basis with the regular medications. Good questions. Okay. So, I have another question here. Can a family decide to stop medications and then have hospice evaluate? Stop medications. Do you mind, Mrs. Hetzel, just elaborating on that question a little bit?
Can you hear me?
Oh, yes, I can hear you. Hi.
Hi. I don't want it to sound mean, but with their brain deteriorating, at what point is it, I don't know, ethical or whatever? Like, is there a point that the family can say, we don't want medication, and not necessarily, I'm not talking about like the depression and the anxiety and all the like behavioral ones, but like at what time, or is it possible to do that and have hospice come in? Like cholesterol and other things, or is that like?
That's a great question. No, and it doesn't sound mean whatsoever. I would say if hospice isn't involved and there isn't a registered nurse coming into the home yet at that point, I would consult your physician and talk with them through that. And then if hospice is coming in to evaluate, making those preferences known, because hospice works with the patient's attending physician, and then hospice also has a medical director and consulting physicians that we work with as well. So anything that the family wants and the patient wants, we can run that through, and it's always a case-by-case basis. But I would say typically to consult your physician if hospice isn't on board, and see if they can establish a hospice provider coming in to do an evaluation. And then once hospice gets there, making those needs known, or what the expectation is with the medications, or talking through that. And chances are they will discontinue them. We just have to run it up the proper channels. Does that answer your question? Okay, great, wonderful. Okay, so I see how often do the various hospice workers see the patient. So we're gonna dive into that here in a minute. Great questions, you guys, this is wonderful. So who delivers hospice services? So when you think about a hospice care team, our patient and family and friends are at the middle of our care that we're providing. So a lot of times we just think of the patient, but the family, is at the center of what we do as well. So you'll have the physician, which I just touched on. You have the attending physician, and you also have a hospice medical director as well. You have a registered nurse or LPN, a hospice aide, a social worker, a chaplain, and a team of volunteers. So we're going to dive into each one of those disciplines and kind of go through how often they come, what their primary function is, and things like that. So our first one that we're going to discuss is the nurse. So we call them our nurse case managers, and they are RNs, they can be LPNs. They are able to be reached 24 hours a day, 7 days a week, 365 days a year. So they are experts in pain and symptom management, They work with our hospice medical director and the attending physician in that pain and symptom management. They provide education to family and caregivers on the disease process, what to expect, and the visits. So their visit frequencies range. So every patient's care plan is going to be individualized. So when we first see a patient, the nurse is responsible to develop a care plan of the frequency of visits, who is coming, what are they doing to meet the needs of the patient and family. I would say a good rule of thumb, and a lot of hospices typically start out at 2 to 3 times per week, and we call those routine visits with a registered nurse. So I say this loosely because it's all individualized and care planned. Some people only want a nurse to come in once a week, might be a little bit more independent, just want to, keep monitored, have their vitals taken, make sure everything is under control. The nurse comes in 1 time per week. If they have more needs, they might start out 2 to 3 times per week. And then as our patients decline, or if there's a symptom that we don't feel is managed that we need to be watching, we can increase the nurse visits up to daily. So that's where a nurse sees the patient Monday through Sunday. And the nurse will be very honest with you on admission, the first initial visit, on how many visits they're going to be providing. But a good rule of thumb is 2 to 3 times per week for the nurse. So we're going to move on to our hospice aides. And our hospice aides, they perform a variety of personal care. Do you mind, Jamie, switching my screen if you don't mind? I started to dive in and kind of jumped ahead of myself. Thank you. Okay. Our hospice aides provide a variety of personal care needs. So when I say personal care, that can be anything from bathing, dressing, shaving, assistance to eat a snack or a meal on their visit, light meal preparation, light housekeeping tasks. They can provide a variety of those functions. They also provide education to the family and caregivers on what the personal care needs are and how to complete those tasks when our aides are not there. So they are very similar to the RN in that their frequency is care planned and individualized to the need of the patient. So another good rule of thumb with the hospice aide is that they're typically going to start 2 to 3 times per week. You don't have to have the hospice aide at all. So it's something that's offered. Not everybody takes advantage of it. Maybe they have lots of support, caregiver services already in place that they don't want extra people into the home, and that's okay. But the hospice aide typically starts out 2 to 3 times per week. Their visits are about an hour long. And if the nurse would increase her visits up to daily, she would also increase those visits for the CNA or the hospice aide to 5 times per week. So it's very fluid, we say, and we kind of use a jumping off point that if we need to tailor it down, we can, or increase the visits, we can as well. So the next person we have on here is our social workers. So our social workers are amazing. I mean, every discipline is amazing in their own way. I just say, I laugh because I feel like our social workers have a toolkit that's about a mile long in this huge bag that they carry with resources to the community. But they complete a psychosocial assessment of the patient and the family within 5 days of admission. And that's really just a way of saying that they come into the home and make a visit and just be a listening ear and talk with the patient and family. And sometimes we identify needs, whether it's trying to find more caregivers out in the community, or maybe it's just lending a listening ear and maybe providing counseling for patients and families. And they assist in assessing community resources. So like I said, that toolkit, it's about a mile long. And I mean, they've helped with life alerts for patients that I've seen. They've helped with nursing home placement or personal care home placement, getting additional caregivers in the home, assisting with advanced directives. I don't know if you've ever looked at some of those forms, but they can be pretty daunting, you know, when you're looking at them by yourself and you don't have somebody sitting next to you to help read them and kind of decipher the verbiage. So they help with all of those things. Oh, and I see Jamie. I can confirm the social worker for my family was phenomenal, and they continued to check in on us for a whole year after my loved one passed. It was very comforting. That's wonderful. They're so much more than, you know, just those resources, you know, just being that listening ear and being a comfort. They really have a way about what they do.
We did have another comment in the chat from Lisa, who would like to add on the chart that the nursing home and personal care home staff coordinating between hospice doctors and the facility staff can be challenging. And she'd be interested in hearing about that as well.
That's great. So it can be, because there's a lot of moving pieces when we look at all of the physicians that are on the team for the patient, all of the facility staff, hospice. It most certainly can be. So my experience and collaboration with those service providers is allowing a very open line of communication. And communication is absolutely key to keeping everybody on the same page. Now, with facilities, you know, they typically have 3 different shifts. You know, hospice has on-call nurses that it might not always be the routine nurse. But just I would say the best rule of thumb there is asking the nursing home or personal care. They're going to give you all of the options regarding hospice and what is out there. But a good question to ask is, you know, who are providers that are in the building already? And when they give you those providers, maybe interviewing those hospice providers and asking what their communication process looks like with that facility. Because it is really important to have good communication. Now, hospice does put a chart, a binder with all of the hospice records in the nursing facility as well, and those are kept up to date. At least every 2 weeks, new notes are going in. But I would just say to most certainly find out who's there in the facility. And then when you're interviewing those hospices, I would most certainly ask what their communication process is. And I would say too, if you're wanting to give a compliment on communication or a concern, I would definitely address it if you already have hospice in place in something that they call care plan meetings. So a lot of our facilities have care plan meetings, or they all call them something a little bit different, but generally it's a care plan meeting where they're able to invite family in, and it's a patient-centered meeting. And typically hospice is also invited. If they're not, I would make sure to communicate with the facility you'd like them to be invited, because that's a good way to keep everybody on the same page as well. That's a great question. I'm sorry I missed that. Okay, and then I see Jamie. So we did talk a little bit about hospice diagnosis. So I will go back over that real quick with you. So common hospice diagnosis include COPD, cancer, ALS, renal disease, dementia, Alzheimer's, CHF, AIDS, and stroke and coma. Okay. Great questions you guys have. So we're going to jump back to our hospice care team, but please keep popping questions in the chat. We're going to move on from our social worker to our chaplain and bereavement coordinators. So our chaplain and bereavement coordinators, oh, I see a hand raised. Go ahead, chat moderator.
Hi, this is Jeannie, and you didn't mention cachexia. Is cachexia still a diagnosis, failure to thrive?
It's not used as a primary hospice diagnosis. It used to be. So it can contribute to a primary diagnosis, but not used as a primary, and that is a great question. And I'm going to give you guys some really great resources too here in a couple of slides for some really great, there's a National Hospice and Palliative Care Organization. There's really great tools on there. And then also a comparison tool for resources out in the community. That's a great question. So chaplains and bereavement coordinators, so they offer a care from a non-denominational perspective. They provide bereavement services. So the services that are provided are 13 months after a loved one has passed. And that consists of mailings, phone calls, one-on-one visits when appropriate, grief support groups, and then everybody does something a little bit different on how they host an annual service. We do a celebration of life service, which is a service that's used for everyone to come back together after a loved one's passing to celebrate and honor their life. So then the next disciplines that we have are our volunteer group. Very, very special group of people. They provide patient support. They can make visits to our patients and families. They can help out in our offices. They make crafts for our patients to enjoy. But some things that they can do on their visits include companionship, playing music, watching TV, playing board games, going outside for a walk. The only thing with the volunteer, though, is that they're not able to assist in any kind of personal care needs like what the hospice aide would do. It's more for companionship and life enrichment, or maybe to sit with somebody while their caregiver goes down the road to pick up a prescription or attend church or things like that. So my next slide is, how is hospice care delivered? So we touched a little bit about the care team. And so when we're looking at hospice care and how that all meshes together, the patient is, of course, at the center and the family. And then there is the primary caregiver. So generally that's family or friend. And family members serve as the primary caregiver when appropriate, helps make decisions for the patient. And then members of our hospice team make those regular visits, as we were talking about, to assess the patient and provide additional care or other additional services. So the hospice team is developing a care plan that meets each patient's individual needs regarding pain management and symptom control, and meeting their psychosocial needs, and supporting that primary caregiver. So when we look at all of the people who are providing care, you have your caregiver, and then you also have your hospice team. And your hospice team is there to help educate and support that caregiver, to make sure they have all the tools to feel confident and comfortable in what they're doing as well. So I did see during the beginning of the pandemic, when did hospice start going back in to see patients? That is a great question. So the beginning of the pandemic was a little bit tricky. I know we were all told 2 weeks, right? And then we hit 2 years and we're all like, oh my goodness. So the pandemic looked a little bit different for hospice. So for our home patients, it really depended on the comfortability of our families. We, of course, are not going to go into the home where they want to remain with us, not in the home. They're very cautious of COVID. So we were able to go into every single place that we had patients in the private home and nursing homes. It just depended on their preferences. And we did wear the whole getup, and we still are wearing a lot of the getup, the mask, the N95 mask, and all of the different things to make sure that our patients are safe. But it looked a little bit different when we started going back into places. Nursing homes, it all just depended. Everybody seemed to interpret different guidelines differently, and there were a lot of things that were put down that maybe something was put down one day and then it was changed the next day. So it was difficult, but we pretty much are back in 100% seeing our patients the way that we were prior to the pandemic, still wearing PPE as well. And then I have another one. Do volunteers do fundraising? So that's a great question. We've never used our volunteers for fundraising. I think it would just depend on, I know that different hospices have different causes and things that they get involved in to support. Some might support the Alzheimer's Association or different veterans programs. So I would just say to ask the organization if they do fundraising and what they might work with. So I have from Jamie Rose, she's worked with some of the hospice team members and they are pretty big advocates for their patients in care plan meetings with facilities. Absolutely. We say that we are contracted, to the facility, so we're not employed by the facility. And, the number one, not necessarily the number one, but a huge important piece of what we do is advocacy for our patients. So yes, absolutely. Thank you for sharing that, Jamie. Great questions. Okay, so moving on to our next slide, making an informed choice about hospice. So I threw up some questions here, and there are some more questions that I'll share with you, but there are certain questions that could be good to ask when you're interviewing a hospice provider for your loved one. So a good question could be, how do you work with the patient's family physician? So it's really important to make sure that that family physician and that hospice have a really good relationship with updates, keeping open line of communication to avoid any challenges. What is your response time after hours and on the weekends if there is a crisis? So that's a great question. I would ask that to every provider. It's just good to gauge, especially if you're in a private home and your loved one is not in a nursing home where there are nurses and there are aides, to know how long it's going to take potentially for somebody to get there. I would ask for maybe a best case scenario and a worst case scenario. It should be less than an hour. They should be able to get to you in less than an hour, but I would most certainly ask that question. How often do your nurses and aides typically visit? So we did kind of go over that and what a good rule of thumb is, but every hospice operates a little bit different. It is care plan driven, but the interpretation of that with, the nurses can vary a little bit. So some that I don't have up on the screen, how long has your company been in business in the area? What types of insurance and payment do you accept? So if you're looking again at that private insurance, asking them if they accept your loved one's certain insurance. Who are your hospice medical directors and how involved are they? So we talked a little bit about having the family physician and then also a physician related directly to the hospice. And that hospice medical director is truly a lifeline for us. They are on call, just like our nurses are 24/7. That way, if we have a need, if a patient is in distress and needs pain or symptom management, that we can get those medications in a timely manner. It's very important. Is there a dedicated triage on-call team? And if a higher level of care is needed, what facilities do you partner with? So if you're in the home setting and it gets a little bit too difficult, maybe to care for your loved one at home, and you want to start to look at options, or if your loved one could have unmanaged symptoms in the future, we can never see into the future. Knowing what resources you have right in your community and what your hospice partners with is very important to get you that additional layer of support that you need. And I am going to give a couple of resources, so I'm going to pop them in the chat, that way everybody has them. The first one is nhpco.org. So that's the National Hospice and Palliative Care Organization. So that is going to be a really great resource about a lot of the things we talked about, and more, a lot more. And it goes into palliative care as well. So I got a question here. Does the hospice medical director go to see the patient, and how often? That is a wonderful question. So the hospice medical director typically does not make routine visits the way that our care team does. So we talked about the nurse and the aide and the chaplain, social worker, and volunteers. The medical director isn't seeing them on a weekly basis generally. When they're typically seeing them is at the end of their benefit periods. So hospice runs benefit periods kind of on the back end, and the benefit periods are important. So the first 2 are 90 days. And then after those 2 90 days, it's every 60 days after that. And once they start going into those 60-day benefit periods, the hospice medical director, or it can even be a nurse practitioner, can go out and see that patient and make sure that they still qualify for services and make sure that all of their needs are met. The reason why the medical directors and our nurse practitioners aren't seeing our patients on a weekly basis is because that is really their lifeline into the home and into the on the third benefit period, which would be after the first 2 90 days. And then they would come in every 60 days after that. Okay, so I popped in the nhpco.org. So that is what I said, there's tons of resources on there. It gives you so much information to look at hospice. And then I'm also going to pop in another one here in the chat. And this one I would highlight, circle, star, write down, and take a picture of. It's medicare.gov. So in medicare.gov, when you go there and you click on the right-hand corner of the screen, there's going to be up in the upper right-hand corner, there's 3 little lines, and you click on that. You're going to want to select providers and services. And I'm going to write that in here too. So when you select providers and services, you can click Find Care Providers, and you are able to look up and see quality scores for physicians, for hospitals, nursing homes, home health agencies, hospice. You can really see basically anything related to health. There's dialysis clinics there. And each are rated in a different way. But a lot of those come from feedback, from families that have utilized those services in the community, and also state surveys. We're subject to state surveys through the Department of Health, as well as we do the ACHC and accreditation. So I would definitely recommend you can narrow down your area and what you're searching, and the certain specialty that you want to search. And then for hospice specifically, you can look at family and caregiver experience. So that'll basically give you the overall summary of different surveys that families have submitted that use the services. And then also you can look at their quality of patient care. So those are two really good things that when you are looking for a provider, I would definitely look at those. And I know that a lot of places, when they do offer hospice as an option, they show what everybody's different scores are. And I think that's really important to do a little bit of digging in that research to know a little bit about the services. So that's it for the presentation part. We covered a lot of material in a very short amount of time. So I so greatly appreciate you guys being so interactive. Does anybody have any questions of anything that we didn't go over, or something that you want to talk about a little bit further?
This is Brenda, and I was just going to bring up that I just had an unfortunate circumstance between hospice and the facility where communication was not correct between the two organizations and created a bit of a kerfuffle with my mother's care.
Mm-hmm.
So I would ask that question as well. What is your vehicle of communication with the facility and the communication back with the family, so that everyone's aligned and we don't have a disparity of what's to happen for the patient? That is an important question.
Thank you for sharing that feedback. And I am so sorry that you had to experience that, but thankful that you shared that experience to help others navigate through that as well. Anybody else? All right. Well, I appreciate you guys so much for jumping on here and talking about this. I feel like we kind of need to normalize the conversation a little bit to make sure that we're understanding. I always say knowledge is power, and just having that information that, if it does come time to look into that a little bit further, you feel empowered and educated about the services that are out there. So I so greatly appreciate, Jamie, thank you for contacting us to hop on here. If anybody has any other questions, please direct those to Jamie, and we can help get you the answers. But if you didn't write those two different resources down, I would most certainly say to write those down and take a look. Take a look at if you're looking at services for your loved one. They're very helpful.
Yes, thank you
Thank
so
you,
much.
everybody.
All righty, so we'll briefly cover our upcoming meeting topics. April 5th, we are going to hear from Kathy Kubik, Carrie. The third package for the Department of Health regulation update will be available. And then on April 19th, we're going to hear from our peers. So they are going to come on as a panel discussion for us. And I did want to bring it to everybody's attention that the first week of May, we're actually going to not have a meeting. All of our staff will actually be at a conference that week. So just to make things a little easier, we're not going to have a meeting that day. And as always, thank you, everyone, for attending this evening, especially Sydney. Thank you so much for presenting. We definitely appreciate it. And if anybody has any specific concerns or complaints, you can direct those over to Jay at the State Ombudsman Office at 717-783-8975, or shoot him an email at ltc-ombudsman@pa.gov. Thank you guys so much. Have a great evening.